Hello, welcome. We'll get started right at the top of the hour. We'll ask that you please put into chat your name and your organization. Okay, and there it is, top of the hour. Everybody, welcome. This is Nursing Home Quality Essentials. My name is Tina Conyers. I'm a Quality Improvement Facilitator with Telegen. I'll be hosting today. Make sure that you have us added in your email contacts. Sign up for our listserv. One of the best things about it is peer-to-peer sharing with other nursing home teams from across our 4 states. We also have these no-cost assessments that you can take as a gap analysis, see where you line up, see if there's any room for improvement. We'll get started. Our topic today is best practices in caring for those with dementia. Our objectives are to share these evidence-based best practices. We want to discuss strategies that can enhance quality of life for residents. And then we want to examine some resources to improve outcomes for people with dementia in long-term care. Now, there are currently more than 3 million nursing home residents who are diagnosed with Alzheimer's and related dementias. This year, the health and long-term care costs associated with dementia are projected to reach $360 billion. Now we know that this comes with a decrease in quality of life and a spectrum of emotional, perceptual, and behavioral disturbances. Things we're all very familiar with, like agitation, depression, anxiety, apathy, wandering, sleep and appetite changes, just to name a few. I want to touch on person-centered care, since this is really the heart of best practices for all residents. Person-centered care planning, this is that process that's directed by the person and their representative to identify their strengths and capacities, their preferences, their needs, and the desired outcomes of that resident and their goals for care. So the person and their representative, they are meant to direct this process, and we are meant to facilitate it. They are equal partners in the planning of their care. So we need to have a picture of the life events of the resident, those moments that were loved and those that were traumatizing. We need to be aware of the relationships that mattered, the roles that this person held, and the lifelong routines that they were accustomed to. And then once we know more about what makes this person tick, then we can customize the approaches utilized in their care plan. Now, family, friends, neighbors of the resident can provide vital information about the person with dementia if they're no longer able to communicate those kind of complex thoughts themselves. That's recommended to develop systems for collecting and also disseminating person-centered information. It's really important that all of the staff know the person living with dementia as an individual. And we want to establish procedures for collecting that person-centered information, including those choices, life history. It's also really essential and easily missed, though. We need an effective process for sharing that information out with all staff. It's no use if it's just sitting in a book. This is an example of a person-centered care plan written up in the I format. You can see it's more of an informal sort of setup. It reads kind of like a story about the person. Here's another example I think is worth sharing. This format, it includes sections for concerns, goals, person-centered interventions, and then also which interventions are best suited to be utilized by which types of staff. And you'll think, oh, you're going way too fast through these. And I am. There's a lot of information that I already whittled down so much. And y'all will get these slides. And if you want any more of this, you email me and I will get set up with you. The 5 Ps, this is from Teepa Snow. These are concepts to consider when you're creating a schedule for a person with dementia in order to give them a sense of purpose, to provide cognitive stimulation, and to increase daily moments of enjoyment. They stand for place, people, props, programming, and possibilities. So for place, this is an environmental analysis. We want to be asking, well, what about our setting needs to change? What's missing? What's not working well? What is working well that we can capitalize on? For people, and what do we need to know about them? What do they need to know how to do or be aware of? Are they interacting with the right match of staff and fellow residents? Props is all about the surrounding objects and items. Are they meeting our expectations for what we need them to do? Can we think of an alternative that would be a better match for a person's interests and for their abilities? For programming, we want to ask about how much time staff has to offer support to each individual. How is time being used? What's the rhythm of the day look like? And what's the balance between purposeful engagement, pleasurable enjoyment, personal care completion, and periods of rest? And then finally, possibilities. And we want to ask ourselves, what's something new we can try? And how will we know if we're making meaningful progress in this? And how can we help staff explore new options that may improve outcomes? So, how can we problem solve? Well, there are a lot of variables and modifications that can be made to improve how a person functions in their task, in their space, and in their body. Now, when it's an issue within an action, test out breaking down those steps to their most basic components. Provide sequencing pictures to support their ability to complete a task. You begin part of the task, ask them to finish. All of these little things that help them maintain independence for as long as possible. Changes that you can make in a person's space include decluttering. This is a big one that I see missed a lot of the time. Taking out some of the visual noise, so to speak, and identifying possible sources of overstimulation. Maybe there's too much on the walls. Maybe their room is in a really noisy part of the hallway or the home. And is there an obvious rhyme and reason within the setup and the flow of the space? Is there a way to make the space more like the one they had at home? Whether that's in the layout of things or with familiar objects. And finally, what might be going on in their body that we can look at and evaluate? So one of the big issues when you're working with a person with dementia is behaviors, right? And that's why we have historically had such an issue with antipsychotic medication being given off label. When you have a person in intense distress, what's the best course of action to help them regulate their emotions? Well, first, make sure that you're acknowledging their reality and make sure everyone on your staff isn't trying to provide orientation or trying to use reasoning to smooth over their feelings. Um, do provide genuine, empathetic, and non judgmental comments. This is a big one. Help give them the language that they need to name their emotional state. Um, at the risk of sounding pedantic, I feel like this right here is kind of like magic. I can't tell you how many times I've been working with a person who is just in a rage and they can't find that language and you can give it to them and it doesn't have to be appropriate either because feelings often aren't. I had one gentleman who really struggled with this and um I'd say, hey, it looks like you feel pissed off, and he just immediately, like, you could see the relief was palpable on his face. He was like, yes, yeah, I'm pissed. But being able to give that name to that feeling helped get that under control for him in a way that was so much faster than anything else. Look at your body language and your tone of voice and make sure that they're both conveying a sense of comfort and warmth to the person, remembering that they may begin to mirror you. And give them a compliment about speaking their mind, thank them for coming to you with how they feel. And lastly, allow for negative feelings. I know when we try to steamroll over them, even though we have the best intentions, right? We just want them to feel better as fast as possible. If we steamroll over, it often creates more strife and more effort to return to baseline. Finally, here, I just want to really emphasize the importance of staff training, formal staff training in de-escalation techniques. And Center of Excellence is a fabulous resource for that. Now, behavior is a form of communication. Actions are meaningful. And we know that the words that we use only account for about 10% of total communication. Now, we know that nonverbal language skills remain a strength in people with dementia, and this can be capitalized on. Because that person, they're trying very hard just to make sense of what's going on in their environment. They may be embarrassed or scared or frustrated about not understanding conversations or directions. We're going to go more in depth about the verbal and nonverbal strategies that we can employ to improve that communication with residents with dementia. Nonverbal strategies, make sure that you're approaching from the front. As we age, just natural healthy aging, and also exacerbated with dementia, we start to lose our senses and we start to lose our filters, right? So with vision, we know that with a person with dementia, it can be more like wearing a scuba mask, right? And if you do the dorky thing, you take your hands up like you're pretending it's a scuba mask, you see like you cut off so much peripheral vision. And that is what a person with dementia might be seeing. So if you're coming from the side or behind and tapping a shoulder, man, that's kind of alarming. Be sure you're always approaching people from the front. Be alert to where your body language is saying. Make eye contact with a person. Be sure that you're always speaking at their level. If they're standing, you're standing. If they're sitting, you're sitting. And be sure to use gestures to point or demonstrate to help with that comprehension of what's going on. Verbal strategies, make sure that as much as you can, take out those distracting noises. So maybe that's closing the doorway to a hallway. Maybe that's turning down the volume on the TV. The best way to start is by getting that person's attention by saying their name and then reintroduce yourself. Um, this one is very difficult for me to do, using short and simple sentences and also pausing after about every 2 to 3 sentences. So we know that the brain's like a computer, and as we age, just like a computer ages, it takes more time to process. So those pauses are really necessary for a person to process that information, to understand it, and then process the words that they want to say to respond to it. When we're working with people, whether it's picking out a menu choices with them, or clothing options, or activities list, give 3 choices maximum. I recommend 2. It does take longer, but if we go past 3, then we start to lose memory of certain options. It starts to get kind of frustrating and stressful. 2 to 3 simple choices at a time. Do you want this blue shirt or this red shirt today? Making sure we give one short instruction at a time. It's not always realistic to be able to give a 2-step instruction and expect success with a person with dementia. And then the final thing, and probably the most important on this list, giving that ample wait time for them to process and respond. We tend to miss this a lot. What are some strategies we can use to help improve people's participation with care tasks? Well, we're going to work in routines as much as is feasible, right? It's not realistic to say we do the exact same things every time, every day, but where we can, we will. Be sure that everybody is still using respect when they approach, knocking on the door, saying who it is, getting permission to come in, starting off on the right foot. Provide scaffolding as needing. I love this phrase, scaffolding. It just provides that support that somebody needs to stand on their own and do what they can do on their own. So sometimes that's giving just like a verbal prompt, oh, hey, next up, you're going to put on your shirt, right? Scaffolding maybe is hand over hand while they're eating. They're having trouble getting started, but if I put their hand under my hand, they're grasping their spoon, I'm helping them with their oatmeal. After about 3 bites, they're going to be able to do that on their own. Make sure everybody is demonstrating. Words aren't enough. We're going to show a person and give them a visual of what we're asking them to do. and making sure that there's a lot of effort that goes into conscientiously praising all of these successes that happen and all of these efforts that a person is giving. And lastly, for improved participation, the minute a person starts getting frustrated is the minute that you stop and you take a break and you either provide support or you try something different and then come back to the thing later. All right, let's talk about unplanned transfers. These are a major quality and safety challenge. We know that people with dementia are at a greater risk of potentially avoidable hospitalization for chronic conditions. Now, discussing goals of care through a structured discussion with family, this can reduce those unplanned transfers. Looking at the research, the literature, in facilities with lower rates of unplanned transfers, they had an increased ratio of updated advanced care plans. In these homes, the nurse gives medications rather than delegating the task to med aides. They described that good palliative nursing care planning was in place, and having an informed and involved immediate family was necessary to avoid acute transfers to the emergency department. Um, Lastly, the resident should never be experiencing any pain or anxiety or respiratory difficulties. So in these homes that had reduced transfers, the GPs, they prescribed a standard set of medications when a resident was in the palliative phase so that that medication would be readily available in the nursing home. When it's agreeable to the residents, choosing clothes with elastic and avoiding clothes with buttons and zippers can make independent dressing more achievable. Again, we're going to be just giving one simple direction at a time. And we can provide support by laying out clothes sequentially. So when we lay clothes out on the bed, underwear are going to be placed on top of pants. A bra will be placed on top of a shirt. It's just about setting up the environment for a greater chance of success. When it comes to toileting, we want to continue to promote privacy and make efforts to maintain personal dignity. It's recommended for people with dementia to have a timed pattern of scheduled bathroom visits. Now, for those with higher levels of cognitive functioning, this may be as easy as giving verbal reminders throughout the day. We want to set up their environment for success, so we might print a photo of the bathroom and put the word bathroom or toilet underneath, and then put that sign up on the bathroom door that faces into the bedroom. Of course, we want to be utilizing constipation prevention strategies. We want to encourage fluids during the daytime to avoid increasing the amount of nighttime bathroom trips. And it's recommended to have therapy screen for a person's capacity to engage in pelvic floor exercises for bladder training. Eating. How spectacular does this video look, by the way? My gosh. Okay. Maintain familiar dining routines, breakfast in the morning, lunch around midday, dinner in the evening, as much as you can while still respecting those preferences a person sets for their own meal times. It's recommended to facilitate social eating and to set people up for success. And again, the highest level of independence, we can provide those kind of verbal reminders to people or encouragement or physical cues if that person isn't able to eat or drink on their own at a functional and a safe pace. We're going to provide a quiet, relaxing, home-like atmosphere. We're going to make sure that there's not a loud TV on in the background so that a person can really give their attention to the food. Using colored plates to provide contrast to make food easier to see is a great strategy. In the research on this, I think it was over a period of 3 days, the average person increased their caloric intake by 500 calories, which is no small thing. The last thing is preparing food just to maximize acceptance based on taste. Typically, a lot of people with dementia do prefer sweeter tastes. There's one woman that I worked with, and she had gone down to about 25% intake for any kind of meal, and she was on a pureed diet for years. And she was needing supplements and supplements, and just had the idea of, the little maple syrup packet, right, that comes for breakfast. We added that to yogurt. We added that to soup. We added that to a lot of things. And my God, her intake went up to 50%. It's not a huge amount, but it was still something for one little packet to make a big difference. For the sake of time today, I'm going to skip the slide because this topic, it really deserves its own half hour. And honestly, it could be given several hours. So if reducing inappropriate antipsychotic use is on your to-do list, please reach out to us at Telegen for one-to-one support, because there is a lot that we can do with you to make this process easier. And it deserves more than just one little slide in this presentation. So please reach out to us for more assistance on reducing antipsychotic medication use. All right, next we're going to talk about sleep. So compared with community dwelling older adults, long-term care residents with and without dementia both showed significantly lower sleep efficiency. They showed longer awake time and more sleep fragmentation throughout the night. Now, staff distress, resident agitation, and psychotropic medication prescriptions are all associated with sleep disturbances. CMS, they developed a toolkit that offers education and person-centered, really practical, non-pharmacological interventions that nursing home administrators, directors of nursing, and bedside staff can implement that can promote high-quality sleep for residents living with dementia. It includes a sleep environment scan, identify areas to focus on for improvement, and it provides specific approaches to help in those areas. It's called the DREAM Toolkit, and we'll have a link to this on this slide as well as on the resource slide at the end of this presentation. When it comes to training and educating staff, make sure that your orientation and annual competency trainings include best practices for working with those with dementia. Teepa Snow mentions in one of her presentations that nursing aides get something like 20 hours of training overall for dementia, and nail technicians at a nail salon get something like 300 to 400 hours depending on the state. Make sure that you're equipping people with the information they need to do so that they can be doing their best at your home. Further on this, it's recommended to have a mentorship program so that those who need that extra support in this area will have a person to be able to learn from. One other thing too, we know that healthcare in general can be very difficult to work in. Burnout is a very significant thing. Having an informal or formal support group for your staff members who are working directly and consistently with people with dementia isn't a bad idea if your staff are open to that idea. How do you measure success with this? Within quality improvement, one question we're always asking is, how will we know if any change is an improvement rather than just a change? Quality of life, it can be difficult to measure since it's a lot more esoteric than a simple yes, no kind of setup. And people with dementia are not always verbal enough to be able to describe this to a person, for a survey. Now, one of my assigned homes, they have this incredible program. They call it Divert to Avert. It's about using redirection and in distraction, engagement in projects and activities as a means to reduce falls and reduce behaviors. Now, tracking quality measures like those can be a metric to judge how successful your home is with implementing best practices for people with dementia. Routine surveys with residents who are able to participate and surveys of their family and representative satisfaction can provide excellent data to help quantify your improvements. And of course, requesting feedback from your staff as well is imperative, and not just for continuous improvement, but also for sustaining the positive changes that you will have worked hard to make. Recommended action steps need to match the effort and the bandwidth that you have available to give at this time. Now, maybe that's just pulling one of these resources out to take a deeper dive into exploring. Or maybe you have a specific resident in mind who's really struggling and staff are struggling with, who could benefit from a PIP to further individualize their care plan. Perhaps you can take one small process like sleeping, toileting, dressing, or eating, and you can make a small change to incorporate a best practice into your current standard practice. Consider scheduling staff education and training on the communication strategies that can reduce behaviors. And absolutely get in touch with your designated quality improvement facilitator. If you're not sure who that is, please send us an email and we will get you connected. There's never a cost involved with our support. We're non-regulatory and we're really happy to assist. Here are some resources with just a short description underneath them. Please take a look as you're able. Question. Our chat monitor today is Heather. She's going to let me know if any questions pop up in chat. Of course, please feel free to come off of mute too to ask any questions that have come to you during this presentation.
Nothing in chat at the moment.
Okay. Someone might be typing something. It's fine. We're still going to have time for questions because I ran through these slides, but I'm going to continue on for this moment to give you our email addresses. The top is just general inquiries. That middle one there is specific to nursing homes. And then the final one is just me. That's my email address. If you have any questions that come up later, or if you want any more information about these resources, this information, please send me an email. I'd be really happy to get in touch. We've got some great things coming up. Next Tuesday, October 8th, it's going to be NHSN office hours with Kristen. Then that next Thursday, the topic is the heart and soul of healthcare safety, celebrating infection preventionists. And then the Tuesday after that, that's October 15th, the topic is creating a trauma-informed culture for effective workplace development. Now, after the Zoom session ends, a window will pop up for the Nursing Home Quality Essentials post-series assessment. Now, we'd really appreciate it if you could take a minute to share your thoughts about this series. The very final session is going to be on Halloween, October 31st, 2024, and your feedback will be anonymous. We'll provide this assessment for all of these sessions in October, so there's no need to complete it more than once, unless you have additional feedback for the presenter. And please do give us feedback, because that's the way that we become better with our quality as quality improvement facilitators. I want to say a very deep thank you. Thank you for your time and your attention today. And thank you for your commitment to improving dementia care for your residents and for your staff who are working with people who have dementia. We really appreciate the work that you guys are doing day in and day out for your residents. And thank you for that. If you have any questions, again, please get in touch. If you have any want for support or assistance, please get in touch. We're here for you. So again, thank you so much. Hope you guys have a wonderful rest of your week.